Welcome, I'm Karen O'Connell.
And I'm Mike Quinn.
And so I think the importance of today in looking at the future of pediatrics is to incorporate your emergency preparedness into your office and really take a good look at what you are capable of doing and what resources are available to you and how you can be best prepared. So I have nothing to disclose in this conversation today.
And neither do I guess, as we say.
So our objectives today is we would like to review some of the literature with you about office preparedness. It is a hot topic. It's been so over the last decade. A lot of research has been done in and around how prepared we are. I'm feeding.
Okay,
sorry about that. And then we would like to discuss the American Academy of Pediatric recommendations to you as practitioners in the community. And then, since this is our area of expertise, we want to just look over some of the emergency equipment, see what you can offer to your staff and to your patients, and then some of the care delivery, how it's best done. So when you look at children in the community, you will, if you have not already, be faced with a child who presents to your office with some kind of emergency. And if it's not a child, it's a staff member or somebody else in the building which you're working in. And the literature, unfortunately, shows that we are unprepared as primary care physicians in our setting to really optimally care for these children and give them definitive care. We know that, and that's why you guys call 911 or call for transport or have someone sent to an emergency department where they can get definitive care or long-term care. When you do call for those services, the 911s, the local emergency services, as we vary in our practice and our capabilities, so do our pre-hospital providers. So when you have someone who presents to you to help you with your child who's super sick, it's important for us to realize that they may not be as knowledgeable in the pediatric world. They have emergency skills, they have emergency knowledge, but do they have pediatric emergency knowledge? So it's important just to keep that in the back of your mind when you're calling for help. And then we know because of what we do with mock code scenarios and going around to our different units within the hospital, but also in your office, it's important to conduct mock codes, and we'll go over that in a little while, just so that you can become prepared. The more you do it, the more you face, the more questions you ask about your office practice, the less anxiety you'll have and the more confident you will be when the real thing shows up to your office. So looking at some of the literature, Susan Fuchs has been the spearhead in looking at emergency preparedness in the office setting. She's phenomenal. We were actually very pleased and honored to work with her on some of the workshops through the American Academy of Pediatrics. And when she did a very large study, a statewide study, about 62% of the pediatricians saw at least one emergency in their office every week. That varies. What's the definition of emergency? We all have a different definition. But overall, using their definition of needing definitive care there and then being transferred out, about one a week. Another study looked at another a statewide population and a large number of offices, 50 offices. They actually had about 2 a month, okay? So anywhere between 2 to 3 a week to several a month, depending on your population. And then when we define emergencies, you guys, it's not news to you, but respiratory emergencies, respiratory distress are the most common that you will see, and then followed by seizures. And there are those very few scary ones that you do need to be prepared for when it comes to stabilizing your patient, the obstructed airway. When we have siblings of patients who grab a marble of a game that wasn't meant to be in the playroom, they choke on that. You might have a few people who come in shock, especially anaphylaxis, so you might be the very first person they see. So again, emergency preparedness for your office setting has become a very important topic, one that the Emergency Medical Services for Children has addressed, and also one that the American Academy of Pediatrics has put high on their list to conduct research and to conduct interventions so that you are most prepared. You as primary care providers serve a very important role. You're basically the portal to all care for our children, and definitely for the majority of families around the world, you are the very first entry site for emergency care. So for those reasons, it's important for you to know how to give care, how to access the EMS services, understand what your role is in the community, and that's really going to be the crux of what we talk about today. So the American Academy of Pediatrics has made recommendations. They are also printed in the Blue Book, and it goes through how you as an office can be best prepared for emergencies. So starting off, it'll be your self-assessment of your office, what do you have, then patient and family education, staff training and preparation, then the emergency equipment and medicines that are expected to be in your office or recommended to be in your office, and then documentation, what's going on, how do you prepare, what are your policies. Then we'll look at our emergency medical services, and then focus on you in the role of a patient advocate in the emergency environment. So for the, obviously the very first thing that you want to do is look at your office. Okay, what is your office prepared for? What kind of patients do you see? How big is your office? Are you a solo, standalone building? Do you have multiple practices within your site? How many people work in your building? What kind of children do you see? And then what is your staffing pattern? Okay, do you have nights and weekends? Capability for your patients? Is your staffing half the size during those night shifts than it is during the middle of the day? And then look around you in your office. How close are you to the nearest hospital? How long is it going to take for emergency services to get to your door and then that child packaged up and get to a hospital? And then especially in this community and in this environment, you guys are around a tertiary or quaternary care children's hospital, so you're going to see, and your patient population is going to consist of children with special needs. You're going to have the GJ tubes, you're going to have the trachs, you're going to have kids who are either vent dependent or trach to a mist cap. So you're going to see the children who have a lot of different and unusual needs that a lot of emergency services personnel may or may not be prepared to take care of once they do get there. And then lastly, risk management requirements. What does your covering group require that you have? Do you have to have a policy in place to call 911? Or are you required to stabilize and then seek services? So next, focus on the patient and family education. You guys obviously are the absolute best at this. This is why we take our children to you. You care for them really well. But when it comes to emergencies, a lot of parents don't know where to start, and so they're going to call you. Like any stage in life, anticipatory guidance is the key to growing our healthy children up to be healthy little adults. And most offices have handouts that have injury prevention, what's expected at what developmental stage. But keep doing that, and every time you have your appointments, go over what's the child doing, at what age can they get those child-proof pill box lids off, At what age are they opening their own windows and have to have those little, locks for fall prevention, okay? We still see kids fall up and down stairs all the time, okay? They're crawling, climbing, they're really not steady for a long time, and even when you think they're steady, they're still not. But just have that prevention injury in place, hand it to parents, okay? And then also, let parents know how to contact 911 in their area. It's not just 911. So many areas of the country, it's another number, okay? And poison control. So we get that all the time. We get calls to our emergency department asking to send a child or refer a parent from home. Have them call the poison control immediately. There are things that they can do within the home while they're waiting. And we, within the tri-state area, Virginia and DC and Maryland, have the National Capital Poison Center and the numbers there. And then, again, for your patients who are technically and medically complex, make sure that there are advanced directives if it's appropriate, okay? A lot of times kids will come to our emergency department with a very full code. If the parents didn't want that, it's a really disservice to everybody, especially the family and the parents. Going along just real quick for some of the resources, you have this in your handout. I'm not going to go through all of them, but this is a resource to you if you do not already have those anticipatory guidance handouts for your families. This goes through how to teach the parents about emergencies, how to educate them on it. It helps you go through and prepare a fact sheet. So that would be very, very handy and helpful. Mike's going to go over the staff training.
So now that Karen's tired out, I get to talk. You were thinking I was just the eye candy, but no, I can perform too. Yeah. The training that you ought to undergo and realize that what you need to do is kind of have an idea of what to do. There are a lot of different types of training you can have, types of program you can put your staff in, and you have to kind of model it to the staff that you're dealing with. There is no solid, guideline or law, certainly, that says everybody in your office has to have PALS. It might be silly to have some of your secretarial staff doing that, but it's probably a good idea that they at least be familiar with, how to call the ambulance and how to call you and knock on the door, like Dr. Weissman was telling us, and recognize when it is they need to do that. It helps out. So you have to have some office response plan that incorporates everybody there. and incorporates them at their various levels so that they feel like it's part, and you know that they're going to do their part when you're busy, hands-on, doing something to save a life. You've got somebody else who's calling the ambulance, you've got somebody else who's bringing medications, you've got somebody else who's standing there ready to help you. And so knowing how to access 911, having some basic life support knowledge for your medical staff and nursing staff is probably essential. And then advanced training kind of as needed. You not need 15 people who have PALS or ACLS, but you probably need 1 or 2 on site at all times who have that knowledge and that capacity. And what helps, Karen mentioned, doing mock codes, and you remember back in residency, you probably did, mock codes all the time, and they were apropos in a hospital setting, and you say, well, how should I do that in my office? It's probably just a good idea to have people role play, just so that they're used to, when they're busy doing something else, hearing the call to come and help, and then knowing that they've got to go and get the oxygen that's in the cabinet in room number 3, and somebody else has to go and get the medications that are in the box in room number 4 and bring them all together to the right place. Just actually doing it and see what the impediments are will help you when you really need to go and do those things. You always freeze and you always panic when the real situation occurs, and practicing it a couple of times, even if it's not full-blown mock code like you used to do in the PICU or the NICU, really helps. When various studies have been done about what kind of training office staff has actually had, these are back in 04 and 05, Dr. Walsh-Kelly found that lots of places have BLS for the doctors and the nurses, and not so many require it for the receptionists. Not many required PALS even for the physicians, and not many at all required it for the nurses. And not that this is good or bad or otherwise, but just realize that again you need to appropriately for your setting get the right amount of training and spread it out among your staff. There are lots of life support courses. None of them make you a critical care or emergency physician. I'm not sure what really made me an emergency medicine physician. I've certainly taken all these things. What they do is they give you confidence, they give you some exposure and some experience with at least thinking through situations and handling equipment and tools that you might not use every day. And it's just nice sometimes to put them in your hands and think about how to use them and see how they work and realize where they are when you put them away at the end of the day.
And this is an excellent guide, this Office Preparedness for Pediatric Emergencies. It was through the Emergencies Medical Services for Children project. It's one of the Targeted Issues grant. And it's an excellent, it just really marches your office through how to do all these steps that are really critical.
And I think you can basically access this online. Mm-hmm. So when you look at your handout for the name, and you can find this on the internet. Everything has an internet-based access. So when you talk about what kind of equipment do you have to have, do you need a fully stocked emergency department in your office? Well, no, that's kind of crazy. The AAP recommends a couple of things, and it's just interesting to see what is recommended as essential medications. There they are. The ones that you really, really ought to have: oxygen, albuterol, and epinephrine 1 to 1,000. So that's for intramuscular injection for anaphylaxis. No more, no antibiotics. The ones you really need are those 3, and probably most of you have those, or I would expect that you have at least 2. Probably everybody has albuterol, and it's relatively easy to get the oxygen. Essential equipment, a little more elaborate, but still not all that outlandish. An oxygen source, so you have to have the tank. You need a mask to deliver it. You need a bag valve mask device in case you need to give a ventilatory support to someone. Suction, both bulb suction and a suction machine so that you can give oropharyngeal, tonsillar, so-called suction. Masks to deliver the albuterol, oral airways, a dosage guide. There are a number of commercial ones available. People have these available from the PALS course when they take them at Children's, also at University of Maryland. You can get the Brazilo tape and its components, but it's handy, of course, to have one of those things when you need it, because the last thing you need to do is try and remember what the dose of epinephrine is in that situation. If you don't know it, it's so much easier to just look at a piece of paper that tells you. Having a blood pressure cuff, a CPR board. Karen, I will not be able to stop Karen from talking when we get to the effectiveness of giving chest compressions. You need to have some kind of a firm surface on which to apply the pressure you're going to give if you need to give CPR. Otherwise, it really doesn't work that well. And it's handy to have some splints and some bandages. Suggested medications and suggested equipment, a little bit more extensive, and you can certainly modify these as needed for your office setting. Clearly, having activated charcoal is handy. Antibiotics, if you know that you've got a population where you've got kids who are likely to get infected or who are immunocompromised. Benzodiazepines, handy to be able to treat seizures, and as people become more and more familiar with these, there are more alternate, meaning not IV, means to give these things. They can be given sublingually, and they can be given in the buccal space and still be effective. Corticosteroids, dextrose, Benadryl, epinephrine, and here what they mean is 1 to 10,000 for resuscitation. Atropine and IV fluids. Again, you may not necessarily think you need those, and they are just sort of suggestions. And then same with the equipment, obviously much more advanced with McGill forceps and NP airways, laryngoscopes, ET tubes. Having those, maintaining them gets to be a lot more cost-intensive, gets to be a lot more QA-intensive, because you've got to watch out and make sure that the batteries are recharged, that the light bulbs work on the laryngoscopes. So when you get into the stages of these types of equipment, it requires a lot more effort on your part. The one that I probably would point out that you really might want to consider, because when you walk through airports and Home Depot and practically anywhere these days, having an automated external defibrillator, and one that sort of does the work for you, is I think going to become something that is almost recognized as required by many people. One of the things that we've dealt with in the past through the Code Blue Committee has been our outpatient clinic settings, where we have essentially a medical office in a non-medical office building, and the question came up: what do you do if some person walking down the hall collapses and has a heart attack? Are you responsible to help them? And if you do, what are you going to do for them? Well, if I'm in one of those buildings and I have a heart attack, I hope someone has an AED and puts it on me. It is something that you would be able to have, and something that, as cost comes down and effectiveness for all types of patient populations, children and adults, becomes more effective, it's going to be almost an expectation, I think, in the relatively near future. When again, Dr. Walsh-Kelly looked at what do people really actually have in their offices, here's what they had. Most have albuterol, and almost all have epinephrine. Lots have IV catheters, and the majority have an infant oxygen mask. But once you get past having some IV fluid and benzodiazepines, things start to tail off a little bit. Having intraosseous needles, having endotracheal tubes, not so common, which kind of reflects what you see with the AAP recommendations, which is that the things that you're likely to need on a relatively frequent basis are considered essential. The ones that are, really can be tailored a little bit to your office setting and your patient population, less common. When they asked about, why do you have this and not something else, people basically, again, reflected what their settings are. If you're relatively close to the hospital, if you have rapid response time, and if you don't have a lot of emergencies, then you're less likely to have the more elaborate equipment. And people who lived far away from hospitals, essentially more than 10-minute transport time to hospitals, were in the group that tended to have more emergency equipment. When we presented basically this talk to the AAP conference in October past, it was interesting to talk to folks, who were from this area, but then we had a couple from Idaho, we had one from Wyoming, one international, and they're, basically, they said, we're 5 hours from the nearest hospital, and if we wanted any faster, we need to fly a plane in and land it, and we have to get them to the plane. So, those guys really had to have a lot of equipment and a lot of expertise that you wouldn't really expect in a setting more similar to what we have in a metro area like this.
And so we would like to break up the monotony with some pictures now, because it's important for us to see what are people doing to prepare and to package up their emergency equipment. So you may have some of this stuff in your office, you may have none of it in your office, but this is how you can actually put all of your emergency equipment together in one space so that it's easily accessible. You don't want to go into room 3 to get your IV meds, you don't want to go into room 4 to get your airway stuff. It needs to be in one designated area, and if that's the least that you could do, you take home from here, is go to your office, look and see what you have, see what you need, and then pull it together into one spot. So up there there's traditional code cards with airway breathing interventions. Then you have the Broslo type system, which is the color-coded weight-based system for, say, if you have complicated kids or you see a lot of kids or you don't see a lot of kids, it's just a very foolproof way of getting the right size equipment to the child that you need and the right size medications. There are portable bags in there that you can see, again, color-coded system. And then on the bottom, that Broslo tape, this is really important because we think that we're really good. We're pediatricians, so we see kids of all sizes all day, every day. And we guesstimate their weight all day. Except for in the office, you're lucky because if you get a weight on them, then they're back into a room. But we know from the literature that we as physicians do a terrible job at estimating weights. Parents actually do a better job giving an accurate or estimated accurate weight than anybody else. So if you do that, you're pretty risky if you're going to start giving medications. So a foolproof way is by having something, whether a Broslo type tape or some way of measuring a child based on their length, and they're pretty accurate. There's a lot of questions about this age of obesity. You have children who are a certain length or a certain height, and is that an appropriate or accurate weight? Well, when it's appropriate and accurate for the medicines that we're giving for resuscitation. So when you're looking at medicines and you're giving them, they're in intravascular space, intravascular volume. So the Broslo type system or a system that really guesstimates their weight is appropriate. Okay, if you're going to be dosing benzodiazepines and some other fat-loving drugs, then it probably will not be the best weight. But that's still, again, these are all questions that are still up in the air, and a lot of research needs to be done. Okay.
Yeah.
And then oxygen delivery, okay? You really just need a basic tank and a basic mask, but make sure that mask fits the child's face appropriately. In our frenzy, we're going to grab whatever we have, and there's going to be a lot of leaking of oxygen, so just make sure you have, infant, child, adult, if it's appropriate for your office. And then if you actually have to give breaths and you want to do the ventilation, find, for the most part, the best are the self-inflating bags, okay, which are pictured there. There are a lot of different types of them. It has an oxygen source and a reservoir bag at the end, so you give 100% oxygen. So make sure you choose the right equipment. Okay, that's a BVM mask and bag. Airway medication delivery, the albuterols. I'm sure everybody in here has this capability, but when do you use the spacer device? When do you use just the MDI and some of the handheld equipment? But again, if you have a child who is in severe distress, you want to take the work away from them as much as possible. Okay, so just make sure you have a nice, well-fitting mask for them. My favorite. So CPR. And again, you might never use this on a child at all. And if you saw the etiologies of emergencies that come into your office, it's the last on your list. Okay. So, but what we know from studies, there's a direct correlation with any adult and child outcome with the quality of CPR. Okay. Early CPR, quality CPR. The 2005 guidelines have now made it very basic, and they've focused on pushing fast. Okay, rate of 100, pushing hard. You really need to get a good pulse when you're actually doing chest compressions. And then they've changed around all the breathing and chest compression ratios. All right, it gets confusing. However, if you have a single person, and this is as a reference, if you have a single provider, it's 30 chest compressions to 2 ventilations. And if you have 2 rescuers, for the most part, which will be in most office settings, it's 15 to 2. Okay, and this is when you're just bagging, okay, and doing chest compressions. And then allow, in our frenzy, we're doing it so fast, we don't think to let go of the chest for a second. Doesn't mean take your hands off, you just have to let go, let the chest come back, let the blood fill the heart again. And then just keep doing it, okay? Don't interrupt. Just do chest compressions and keep doing it until you get EMS personnel there.
And the rate for this is basically at about 100 compressions per minute. So,
Fast.
I'm old enough to remember, learning pediatrics. If something goes wrong and someone codes, you need to fix the respiratory problem, and the heart will follow, right? Well, I guess it's important for us as pediatricians to recognize that as we've gotten better and our care has gotten better, we're going to be seeing more and more kids who actually are going to have primary cardiac arrest. And so it's important for us to take this, which is essentially comes from the adult scientific literature, to realize that when you want to resuscitate someone who has had a cardiac problem, you need to make the perfusion effective. I'm jumping in on Karen, but one of the points she always makes is that what you got to realize is that they're telling you to do this pretty fast, 100 compressions a minute with that ratio of breaths to compressions. You get tired really fast. Okay, if you ever have a situation where you need to do CPR, in the back of your mind always should be, who's coming to help me? Okay, you need someone to come and help you, and don't try to be the hero by doing chest compressions for an hour until the ambulance arrives. Do it for about 2 or 3 minutes, and then go back and take a breath yourself and have someone else take over, and coach them along. You want someone to help you with the timing, and the timing is the beat that you follow when you're giving chest compressions.
Yeah.
Okay, well, okay.
Staying alive. Actually, this is a really important thing because, again, at 2 minutes you fatigue. There's all kinds of studies that show your muscles just can't do it. So if you can get into your head that the beat of staying alive, and I'm not going to sing it on stage, it's really fast.
The
okay?
kick drum beat. Okay.
Yeah.
Not the singing. Boom, boom, boom.
Okay, so if you do find yourself in a situation when you are doing CPR and chest compressions on a person, what do you have to sustain that? Is it primary cardiac? Do I need to give them, do I need to defibrillate them and give them energy to get their heart back into the rhythm that's appropriate? This is an AED on your left side of your screen, and a defibrillator is on the right. They both give energy. One involves truly like someone to calculate in the dose. That's a defibrillator. The AED has been shown to be used effectively and faster than physicians in 9-year-olds, because the 9-year-old will put the pads on, they'll listen to the instructions, and then they will hit shock when it says, okay, now hit this button. Whereas we as physicians think about it, and I don't know, is this the right rhythm? So we don't do a very good job of following instructions. But if you want something that's very safe in your office, take the AED, the automated external defibrillator, and store it somewhere. And a lot of times offices can share in this. If you're in a big complex, in a big building, it's important to know, what's your staff like and how many people could potentially use this over time. IV access, again, probably not going to happen in your office setting, but a lot of people do have, both IV catheters up there on the upper left-hand side. But then for advanced and emergent access, you can use IOs. They're the traditional blue Jamsheedes and the little black round ones, the Cook catheters. But now, and we use them a lot in the pre-hospital setting, an easy IO gun. It's basically a drill. It self-guides. It's very easy. Again, depending on your patient population, these are things that you might want to think about. And then your medications. How are they housed? Where are they? What do I need? Some people will have them in one drawer or in one box, like you see there on the left, all lined up. And some will have them in different areas. The one thing that you do need is there in the bottom middle, the EpiPen, that 1 to 1,000 IM Epi for anaphylaxis. It's a very common emergency that presents to your office. And these are just pictures of the other things that are on PALS algorithms. So if you do find yourself wanting to start and you are PALS certified, just have these physically in your space, okay? No one's expected to remember how to go down if all of a sudden a child presents in SVT. Mom brings a baby to your office and says they're not feeding well. They look sick, they're dry, and then sure enough, they're in SVT. If you're prepared to do that, have these available to your staff so that somebody can read and walk you down through the algorithm. Oops, sorry about that.
It's okay. Another component that you need to have is some form of documentation. Again, this is not something that you would necessarily need every day, but it's handy to have, and you probably want to keep papers that are sort of pre-printed and have the outline of what you're going to do stored with your equipment. It serves both as appropriate documentation that you'll have access to, but also if you have the right kind of paperwork, you can almost use it as a prompt to help you go through, and you can adapt the PALS algorithms to this to sort of cue you into, okay, what do you do first? Establish the airway and maintain it, then give support to breathing with oxygen, check the circulation, make sure it's okay, and go through that in your documentation. So for preparation, you want, and indeed one of the sort of regulatory guidelines that you need to follow is if you're going to store all these things and be prepared, you have to have some documentation that you're taking care of it, that it's appropriate equipment, where you have it, and that it's maintained right. So you need to document that. And then for the actual events, the paperwork I'm talking about, where you use it and use it as your prompt to get through the events. Now, talking about EMS, I guess there are a couple things to point out. Obviously, people in your office need to know how to contact 911, when it's appropriate to do so. Usually, that will be when you say, call 911, but they need to know how to do it. They need to know what to say when they're on the line. You need to realize that the EMS service that you get might be somewhat variable. Karen's alluded to the idea that, in fact, you may not have someone who's experienced in pediatrics. You may not have someone who knows exactly as much as you do. Realize that they are going to have good knowledge in how to resuscitate someone who's in distress. And when you interact with them, realize that there is a point at which you should be careful when you step. When they arrive, they're looking at you as the doctor. When you are there and present, if you give them an order or you say that they should do something, they are usually, in most jurisdictions, compelled to follow what you say. Otherwise, they're going to follow their protocols. They might point this out to you, but just realize that sometimes you may get a funny look from them when you say you're going to do something and they're wondering whether you're telling them to do that or whether you're asking them for help. They're there to help, but realize that they have a lot of knowledge and expertise, but it's a paramilitary type organization and they're looking to you as the commanding officer. You may not realize that's what you are, but for them, many times, that is what you are.
And there may be circumstances where you ask for certain medications and they're just not in the protocol, so they're not stocked on the trucks. So you might ask for a certain benzo and they don't have it. So you need to kind of keep an open mind and say, okay, what do you have? What do you have for seizures? If this is a prolonged seizure, I'd like to give something. Or do the parents, do they have something in their purse? Because they can administer it with the help of the parent. Okay, but there are a lot of drugs that the EMS providers do not have on hand. Okay? And then most importantly, just for you guys, it's a whole community, and you all are such a huge part of this community, and if you find that emergency preparedness or emergency response is kind of an interest of yours, share it with everybody, because they really need pediatricians on their advisory boards. They need you to be a part of the ongoing revision of these protocols and the care of their kids, because it's driven by evidence and literature, but it's also real practice. And again, that just goes right into advocacy, okay? Being part of the bigger picture. There are a lot of hospital-based pediatricians here and parts of our division, but make yourselves in the community also very much a part of the hospital pediatric practice. That way we're all doing the same, we all have the same level of care, the same standards of care, we share from each other, and then it will trickle down into the EMS and the pre-hospital environment.
Since Dr. Weissman is waving at us frantically
to
tell us to stop, we're going to stop and say, what questions do you have, and what can we help? Please.
Can you repeat the question?
Sure. The question is, what is your role and responsibility as a pediatrician once you call 911? Remember, you are as a pediatrician, you have basic life support training. You are board certified to be the person who's going to take care of that child or that adult in distress. So there are, you have ABCs, airway, breathing, circulation. You do the best in your basic capability. You're responsible for that person, especially as a physician in your office. Okay. Then there are lots of different ways that you should serve that role in the community. Okay, there's lots of Good Samaritan laws, but when you're in the role of a physician with your own patients, it's a very different responsibility.
Specifically, do you need to get in the ambulance and go with the patient? No, usually you don't. When they're not expecting you to, many times they would probably prefer that you don't, in order that they can deal with their own medical control, whether that's directly online or their established protocols. There could be times when it sure is handy to have somebody else's hands and brain in the ambulance with a really critically ill child. If you can go and you think you can help, I'm sure they would welcome the assistance and welcome having somebody there. That's where you can get in the situation of sort of conflicting, who's in charge. when you do that, God forbid you ever have to do that, but just realize that you really need to collaborate, on the spot in an improvised way. But the answer to your question, no, you don't have to. Sometimes, if you think it would benefit the patient and everybody's on board with it, it could be done. It's not an expectation.
And what would help is when you do have to call 911 and send a patient to any of the surrounding hospitals, it's important to get on the line and call. If it's going by EMS, you're going to be calling medical command. But it would be nice on our end to know what really happened in the office. What did the child get? We all know that communication and handoff communication could use a lot of improvement, and we have a lot to learn. So call us or call the hospital where you were referring to. Definitely speak to somebody and say, this is what happened, this is what I gave. EMS arrived, and this is what the child's state is. Any other questions?
What about, I had a situation many years ago where it was the end of the day, it was the last patient. If I waited for EMS, it was going to be half an hour, an hour. Mm-hmm. So I wanted to take the patient in my car. And yeah. That's my question.
So, okay, to back up.
Yeah, that's a hard one.
It's a tough one. I mean, if you have an emergency, what's the nature of the emergency? It's, if you have any airway issues, I mean, you just, the recommendations are call 911. A lot of people, and I should have put this up there, but a lot of parents and pediatricians will refer children to the emergency room by private vehicle, and that's not uncommon. But even sometimes for things like severe respiratory distress, because I think they're going to get there faster if they go by their car. But you are taking the level of care, and it's actually, we have these violet EMTALA, which regulates how you transfer care. But if you take a child from your office where you have the capability of stabilizing them and really making sure that they're fine, and you stick them in your car where there's absolutely no medical care capabilities whatsoever, you're going down in your level of care that you're providing for that patient. So you really, just from a general medical standpoint, not legal, not, responsibility, but just take that and keep the child in the safest place and bring people to you, because that, next 20 minutes will be the safest if the emergency provider is there.
Yeah,
It's
the
tricky,
nightmare
though. It's
scenario
tricky.
is, if you're driving and something goes wrong in the back seat, what are you going to do? Then you're in trouble. Yes, you feel like you want to do something and make it happen fast, but.
And I'm glad you brought that up, because you know what, it takes a lot to say something like that, and that's not uncommon at all, because you wouldn't believe the number of people who do that. And it's important for us to realize that, yes, I want to get that kid to the place where they can get definitive care the fastest. Keeping them here is going to be the most dangerous thing for my patient, but just take a step back and realize you just need to stop and wait.
I've had this situation, and the place where this actually occurs and where it sometimes is really truly faster to do this was in Manhattan. Okay, because getting the ambulance to you would not happen, and so if you're 2 blocks away from Bellevue, run. Okay.
Yes.
Call me. I'll meet you at the door. That happens.
Are there different liability issues for us because we are physicians if we have an AED in the office and an adult codes or a kid codes? Does that change our liability as opposed to if I'm at Home Depot and I use the Home Depot one?
Yes, it changes your liability. If you're going to, if you embark upon accumulating this type of equipment, clearly you don't want to just do it for fun. You're doing it for a purpose and do these things in a way that is sensible. One of the things you've got to find out is, okay, my malpractice insurance carrier, suppose I do have this, then what? They can tell you, it is a balance between what responsibility do you want to take that may be sort of out of your comfort zone. And I don't mean to make it sound like it's a comfort thing. Your professional capability comfort zone, as opposed to what you think you might need to do. You don't have to save the world. What you want to do is prepare yourself to take care of the emergencies for your patients. And but more and more kids are surviving with cardiac problems who someday might need that. It's going to be handy to know how to use those things.
And you need to just, last comment, we need to make these decisions globally, when you're looking at, should I get an AED or should I not? And really go to the sources like AHA and look at the literature, because, if you have someone who has a primary cardiac arrest and you want to help them out of it, there's significant survival improvement when you catch them at 3 minutes versus 5 minutes versus 8 minutes. And when EMS providers come, or someone comes, usually, some police officers will have AED in their car, that first responder is really not going to get there until that 5 to 8 minute mark. So if you really want to make an improvement and your volume or your patient population says that we have an adequate risk and we should get an AED, then do the research and really know that you'll make a difference with your decisions. Okay, thanks you guys very much.
Thank you very
I
much.
want to thank Drs. O'Connell and Dr. Quinn. As our workforce actually matures, just remember that office AED could be used for you, so, or for me, so maybe we do want to have this present here. Just out of curiosity, by show of hands, how many folks in practice here feel like they have a well-understood office routine for emergencies? All right, so not that many hands. How many folks have ever practiced in an office who would do what? So it looks like there's sort of an opportunity for us to build on this and see what we can sort of develop for our practices over the next year or so that we can sort of raise our game a notch or two.